So hi, everyone. Thanks for joining us today on day one of Siren's National Research Meeting. Hold on. All right, I'm Yuriko Cruz. I'm the Program Manager, Social Drivers of Health at NAC, and I'm joined today by Nalani Tarrant, Deputy Director, Social Drivers of Health, also at NAC. And we're excited to be here with you to share today's content with you all. As a reminder, these are the agreements that have been shared via email, and they're meant to allow all of us to participate authentically and bravely during our time together. And here are 3 ways for all of us to engage with each other. Please share your thoughts and questions in the chat box, and feel free to use the emoji reactions to share how the content has landed on you. And if you're feeling up to it, we'd love for you to share your video feed so we can see each other. And finally, if you're on Twitter, please use the hashtag Siren Racial Equity and tag @Siren_UCSF to share your thoughts on Twitter. All right, so again, thank you for joining us for today's session, using human-centered design principles to enhance cross-sector partnerships that address the social drivers of health. We'd like to thank the Robert Wood Johnson Foundation for their support and funding of this effort.
This meeting.
All right. We're excited that over 1,000 people have registered for this meeting. And if you're hearing about the National Association for Community Health Centers for the first time, here is our mission statement to support community health centers across the country. We're also known as NAC, so I just wanted to share that. And then we encourage you to learn more about NAC's mission, vision, and newly adopted strategic pillars by visiting our website, www.nac.org. So these are the learning objectives for today's session. So we have, at the end of the session, you all will be able to describe how human-centered design principles can be applied specifically to problems of racial inequities in social care and upstream efforts that improve the health of structurally marginalized communities. Understand the importance of integrating community voice, including racial and ethnic groups, and health equity initiatives to improve systems of care. And finally, practice a human-centered design skill so that you're all able to learn experientially. So our first poll is, before we jump into the content, we'd like to get to know who is in the virtual room. Our first poll is to get a sense of who's here and just wanted to get an idea of your familiarity with the design sprint framework. So if we can get the first poll ready to launch.
I believe, Yuriko, that as the host, you actually can launch the poll.
I'm not seeing options to launch the poll. Let's see. So I mean, if folks just want to share in the chat, that's perfectly fine. I'm sorry, not sure what's happening on my side over here, but I can't. Oh, there it goes. There's the poll. All right. So here's the first poll. How familiar are you with the design sprint framework? So again, just wanted to get a sense of all of you that are out there virtually. And it's always good for all of us to see where we're all at. Okay. So far about 20 participants have completed the poll. If others can please complete it, it'd be great. It'd be nice to get to like 50%. That'd be great. All right. So this time, or I'll give you all about 10 more seconds to complete the poll. All right, we're bumping up to 25% of participants. A little bit more than that. All right, so I'll go ahead and end the poll now. I just want to be mindful of time. So here is where you all landed, right? In terms of your familiarity with the design sprint framework. So we've got about 54 of you, about half of you are not familiar, about a quarter of you are somewhat familiar, and then we have folks that are moderately or very familiar. So thank you for joining us. That's really great. All right, and the next poll, let's see. So here's the next poll. I'm going to go ahead and launch that. How comfortable are you with incorporating community voice within racial health equity efforts? All right. So far, we've got about 20% of participants that have completed the poll. So if we can get a couple more, that'd be great. Give about 10 more seconds. Okay. Oh, I'm sorry to hear that the poll isn't launching for some of you all. Sorry to hear that. Oh, that's frustrating. All right, so some of you have been able to find the poll and some of you haven't. And thanks to those that have participated in chat, that's good to see. So I'll go ahead and end the poll now and share the results. So we've got about 7% of us don't feel comfortable, 7 are somewhat comfortable, 40% are moderately comfortable, 33% are very comfortable, and then we've got about 13% at extremely comfortable. So thank you all for taking a moment to share where you're at in terms of incorporating community voice within racial health equity efforts. All right. So again, thank you for participating in the poll. So I want to spend some time talking about structural racism. Structural racism describes the way our systems are structured to produce racial inequalities between white populations and racial and ethnic minorities in the social drivers of health, leading to racial health disparities. Last April, the CDC declared that racism is a serious public health threat, a truth known for painfully too long by structurally marginalized communities. And this particular definition is brought to us by Rukaya Yerbi. She's done some phenomenal work, and this definition really resonates with our team. And part of the definition is also tied to this diagram that she and her team created. So in this diagram, we see the definition really come to life. On the left-hand side are the root causes: racism, sexism, ableism, and classism, to name a few. And moving along, these root causes informs the use of tools of the political process, budgetary decisions, regulations, judicial system decisions, and enforcement. So then as we move along in the diagram, these tools are then used across many systems, such as public health and healthcare, built environment, and education, to name a few. From there, we see the outcomes, and the outcomes that we see are a result of the policies, structures, and systems that are intertwined and deeply rooted within structural racism. All of these elements work together and result in the inequities and health disparities across our communities. Now, with the COVID-19 pandemic and the racial reckoning after George Floyd's murder, the role of structural racism and discrimination and poor health outcomes and inequities has been thrusted to the forefront of health equity efforts. Health centers have been addressing the social needs of their communities by collecting data, but now health centers are stretching beyond meeting the needs of individual patients through utilizing data to inform upstream efforts and to change the systems that create these health inequities. And a key ingredient to addressing racial health inequities is through upstream changes, right? And it's doing this by fostering and nurturing cross-sector partners throughout the healthcare, public health, and social service sectors. So while we recognize the need for cross-sector collaborative efforts between healthcare, public health, and social service systems, in our work, we also became aware that in these relationships and in partnerships, community voice must be centered in health equity efforts. This allows for building trust, sustainability, and more importantly, accountability with community members. So community voice or community engagement can be defined in many ways, such as working collaboratively with respect to issues affecting health and well-being, having shared decision-making, accountability, and community agency, and then also working with community members and organizations to build awareness, gain insight, and develop community capacity. So as we think about what it means to have authentic or meaningful collaboration with community members, it is really important to remember the long-standing impact of the policies, systems, and structures that were used to operationalize structural racism and discrimination. Think about it. Harm has occurred, and individuals from racial and ethnic groups, as well as structurally marginalized communities, are traumatized. Some of these harmful practices have ended, and unfortunately, some of these practices persist. So anchoring community voice is a critical step to acknowledge the harm and the trauma that has occurred. But it also allows us as healthcare practitioners and researchers to unearth the gifts, strengths, and insights from racial and ethnic groups as we reimagine and co-create a more just and equitable path forward. At this point, it is my pleasure to hand it over to Nalani Tarrant, Deputy Director at NACC.
Thanks, Yuriko, and good afternoon, everyone, and thank you for joining our session today. I know there were several sessions you could have joined, so greatly appreciate that you chose to sit in on our session today. So I want to start us off by sharing why we decided to use the design sprint model. In our original proposal to Robert Wood Johnson Foundation, we were originally going to focus on completing an in-person learning collaborative, but due to the pandemic, we had to pivot. We still needed a way to foster an environment to build cross-sector partnerships to address social drivers of health. And in light of what was happening in 2020, we tailored our project to address how can cross-sector partnerships work together to address social drivers of health during the height of COVID. In collaboration with the Association of Asian Pacific Community Health Organizations, or APCHO for short, we decided to pilot the Stanford Design Sprint methodology in a virtual space. The Stanford Design Sprint methodology includes 5 components. We have our emphasize component where we take time to learn about the audience and the community. Our define stage is dedicated to sharpening key questions or identifying a challenge statement. Ideate is where we're brainstorming. We're thinking of solutions that can be used to address the key questions or the challenge statement. Prototype is where we're building out a plan to transfer the created solution into actual actionable steps. And finally, the test is taking that prototype and trying it out and gaining feedback from your colleagues, peers, and the community. Next slide. When we created the program, the facilitators at NACC and APCHO really took the time to think about the program's goals and objectives. We wanted to generate and test concrete ideas focusing on health equity, build an energetic and knowledgeable community as best as possible in a virtual environment, foster a mindset of creativity and resourcefulness, teach participants concrete design tools that they could use in their daily work and with other organizations outside of this project experience, build community commitment and capacity for sustainable cross-sector partnerships, and assess how cross-sector partnerships can best respond to new and emerging SDOH needs that have been impacted by COVID. And lastly, but certainly not least, prioritizing health equity by elevating community voices. Next slide. So as part of selecting teams, we did have an application process. The main requirements included having a FQHC, which is a federally qualified health center, and a community partner of their choice. In addition, we did ask that the folks who were going to participate were able to dedicate the time to join us in all of our design sprint activities. The design sprint experience itself included virtual design sprint workshops, monthly huddles, a pre and post assessment. We hosted a reflection session that we called storytelling and community celebration at the end of the design sprint experience. Each team had a dedicated coach with training and technical assistance as needed. And we also encouraged peer-to-peer learning with the teams. Next slide. So for this design sprint cohort composition, we had 4 cohorts and each cohort had 4 teams. Each cohort focused on a pillar of the Robert Wood Johnson Foundation's theory of change. So we had one on shared purpose, one on data, one on governance, and one on finance. Each cohort was a 3-month design sprint process in which we asked the teams to dedicate a minimum of 15 hours total to this work. Design sprints were hosted on Zoom, and we used Mural as our virtual whiteboard to go through the 5 components of the design sprint process. Usually design sprints, you would have gone through the 5 components in maybe a one-day workshop format, but due to being in a virtual environment and Zoom fatigue and just honestly being considerate of the time we were asking folks to dedicate to the design sprint, we did break it up into 2 half-day workshops that were completed within the same week. The remaining of the cohort time, we brought the teams back on a monthly basis to learn about how their testing period was going. Next slide. So the next few slides, I'm going to provide some demographic data on the participating health centers that will hopefully help paint a fuller picture. This map shows where the health centers were located. The blue pins resemble rural locations and the orange pins were in urban areas. The pie chart showcases the types of partnerships the health centers decided to work with. We had teams come in with 501c3 partners, community foundations, and local government agencies. It was required to have at least one partner, but some teams actually brought in several organizations to work together. Next slide. This bar graph shows the percent of racial and/or ethnic minority patients for each of the participating health centers. And however, what we do see is that the design sprint cohort average is in line with the national health center average. There we go. Next slide. From there, we wanted to get a better understanding of the race and ethnicity breakdown of the patients at each of the health centers. And as you can see on this graph, there's a lot of diversity. And once again, the stats are pretty comparable between the participating health center average and the national FQHC average. A few things I do want to highlight from the participating health centers is that we did see a slightly higher percentage of patients who identified with more than one race with the participating health centers. At 4 of the health centers, majority of the patients are best served in a language other than English. One even noted that their patients speak a range of 92 languages. 2 health centers noted that 50% of their patients are children. And 3 of the health centers serve large refugee populations, including communities from Nepal, Bhutan, and Burma, with 1 serving as a refugee health assessment site. Here, this bar chart represents the percent of patients at each health center that indicate living at or below 100% of the federal poverty level. And what we see is that the national average, 68% of health center patients live at or below 100% federal poverty level, and 63% of patients at the participating health centers live at or below 100% federal poverty level. So once again, very similar statistics with our cohort compared to the national averages. This bar graph breaks up the insurance makeup at each of the health centers, and you can see it varies. While the majority see Medicaid and CHIP patients, other locations see many patients that are uninsured. On average, across the 12 sites, 41% of the patients have Medicaid CHIP, 28% are uninsured, 22% have private or other insurance, and 10% have Medicare. Next slide. So as part of the application process, the teams had to identify at least one focus area that they wanted to create actionable steps with their partner. While the teams identified a good handful of topic areas to work on, 3 themes emerged throughout all teams. They wanted to work with specific populations such as older adults, individuals with complex medical needs, or improving housing availability. They also wanted to identify and address specific health and social needs that were a priority within their community, and build an infrastructure and capacity to improve identifying and addressing social drivers of health in their community. Next slide. So the next few slides, I am going to highlight some of the team's stories. Our first story is from Rock Hill, South Carolina, with Affinity Health Center and Habitat for Humanity. This team originally had in mind to work on housing as their focus of area, but through the design sprint, they were able to learn more about each other's organizations, resources, as well as discussing the needs of the community, which allowed them to work together to host multiple vaccination clinics, COVID vaccines, clinics in predominantly African-American and Black communities. They were also able to establish together a partnership with a local HBCU to focus on equity issues. This partner continues to collaborate and is focusing on improving health outcomes and housing opportunities in their communities and utilizing data-driven strategies to develop equitable funding streams. Our second story is from Springdale, Arkansas, Community Clinic of Northwest Arkansas and the Marshallese Educational Initiative, also known as MEI. So this was actually a new informing partnership that focused on addressing specific health and social needs of their Marshallese community. The team was culturally aware that within the Marshallese community, health matters lie dominantly with the women. So through the design sprint, the partnership worked together to form a Marshallese women focus group. Through the focus group, they identified a gap in the community health center phone triage. Many of the folks who are part of the Marshallese community in Springdale, English is not their first language. So Community Clinic and MEI worked together to create a Marshallese option on the Community Clinic's phone menu. The focus group was such a great experience that the Community Clinic and MEI continue to create a reoccurring women's health night with group education. Next slide. We also had a team from Illinois, Crescent Community Health Center and Community Foundation of Greater Dubuque. And they were utilizing culturally appropriate educational engagement around social drivers of health components as a means to empower Pacific Islander youth. The program involved equipping Pacific Islander students with prepared data and other SDOH information, and then providing them with resources and a platform so that they could take a leadership role and use their natural talents to initiate projects aimed at helping their community. This included working with schools, local colleges, faith-based organizations, nonprofits, and their local government. They also engaged with Pacific Islander elders whose involvement is crucial in preserving the spirit and culture of the local Pacific Islander community. This partnership has also decided to use this same format to include local employers and businesses. And there's also an interest in building a coalition with other Pacific Islander communities around the nation. Next slide. The last story I want to highlight is from Wisconsin. 16th Street Community Health Centers partnered with VIA CDC, which is an active community development corporation focused on housing support and development, economic development, and cultivating grassroots leadership. Acknowledging that both organizations have services and resources that their patients and clients could benefit from, they want to strengthen their partnership to better address housing and other SDOH needs for the Latino communities they both serve. Key to this was building empathy, understanding what services and supports each organization has to offer, finding ways to weave each other's organizations into their ongoing work by including each other in meetings with the larger teams and leadership, and also team building by doing community walk tours that utilize VIA's map of local resources. As a big part of this was thinking about SDOH data that 16th Street collects and how it can be used to help partnership identify patients and clients that can be served together, how they can increase screening on social needs, and how they can share and use that data to facilitate referrals and assess the impact of their partnership over time. In the future, their partnership wants to explore sharing their data with the community to identify the roots of social needs, leverage data for advocacy, and expand their shared data with other community-based organizations. Next slide. So for more stories, you can visit our website, prepare.org, and you can listen to podcasts, view webinars, and enjoy reading brief summaries from the 2021 Design Sprint partners. So I briefly showcased 4. We did have a total of 12 teams, so definitely go and take a look at them. Next slide. This slide really just captures the experience feedback from the teams. Overall, it was a positive experience that the participants said they would do again. And what really stood out is that they enjoyed the dedicated time and the design sprint activities to really assist them in strengthening their partnerships. Next slide. And so now I believe I'm going to hand things back over to Yuriko, who is going to walk everyone through a taste of the design sprint framework.
Thanks so much, Nalani. And just want to acknowledge some of the questions in the chat already, so we'll be sure to answer them shortly. All right, so now at this point, we're excited to provide you all with a taste of the design sprint framework. And we're going to watch this short video from Patty Bell Hastings. She's a design thinking practitioner. What happened? Hold on.
The first step that we're going to talk about in the design thinking process is empathize. And this is where we get to know the humans that we're designing for. And it sounds kind of simple, but it's not. Understanding the feelings, needs, and the pain points of the people that we are working with or designing for is actually trickier, but critical to the design of robust and functional products. There are a couple of things that I want to start out with saying, even though the word is empathize, what we're really talking about here is the research and collection of qualitative and quantitative data. Quantitative data is how many times does someone click on something, or eye tracking movements. Those would be mathematical or quantitative data points. Qualitative data is incorporating a lot of the visual observational research methods. We're trying to identify the feelings and needs of the humans we're designing for, and we're trying to determine problems or pain points in the delivery of our products and services. Now, before we begin, we have to identify and focus on dropping our assumptions, judgments, and biases. If we're designing for a population that's 80 years old, then we have some unconscious or subconscious biases, judgments about what an 80-year-old person is capable of, what their physical parameters are. So we need to figure out what those are first so that we can put them aside, because we really need to go into this in a pure collection, research, data collection frame of mind. The main techniques that we want to use in this process are observation, engagement, and immersion. We need to spend time with the people using our products or potentially using our products if we're designing for them. There are a number of ways to do this, and some of the methods that we teach and that we incorporate in our coursework are basic research, what has been done before, what has been done in the past, what has worked, what hasn't. Interviews, coming up with a questionnaire and delivering it through a survey, or possibly shadowing. If it's service design, we may want to shadow the customers, clients, or people that are using our product so that we can see how they actually do use them or wish to use them. Documentary, it might be, creating a video of the process or product in use, and then sitting back and looking at what we can learn from that, or having people keep journals about what it is that they're using, or it could be a visual journal, it could be a written journal. Body language, also looking at, the person, if it's a website observation, are they hunched over? Are they exhausted? What is their body telling us? So there are lots of different ways to collect this qualitative data that's critical to the design of products that make people happy, that bring them joy, that create the feelings that we want them to have in the use of the things we create.
All right, so that is a really, we really love using that video. And I think every time I watch it, I still learn something new from it. So now that you've heard from Patty, from the expert on design thinking and the phase of empathize, I'd like to share with you all this scenario. So again, we're gonna do a brief taste of the design sprint phase of empathize. So I know that we all work in different roles and different focus areas within health. So this is your chance to try on a new role or a new focus area. So this is the geographic area that we're all working in right now. Let's play pretend. So your organization, the agency you work for, is going to be collaborating with Feeding America. And your geographic service area is a suburban area. It was previously considered rural. It has gone through a lot of changes with 2 factories opening up, as well as small businesses growing as well. And we've been able to observe that the economic growth has been really disparate. We've also seen in the area that there's been an influx of new community members from neighboring states, as well as immigrants from other countries. In terms of racial and ethnic makeup, this is the current breakdown. One thing to note is that in this community, the African-American Black community has grown over the past 10 years, whereas the growth of the Latinx community has occurred within the last 3 years. So 2 different types of demographic changes have been occurring at the same time. All right, so this is our scenario right now. And so one of the activities, so this first activity of the design sprint is empathize. And we'll be using the chat at this time to have you all participate in this activity. Typically, we have 20 minutes for each side, but we don't have that time. So we're just going to have a little bit of time for these. So what we'll do in this time is you can either come off of mute, and my co-facilitator, Nalani, is going to drop in the questions. So the first question that we're going to explore in this scenario is, what are the SDOH needs that you're trying to address through this cross-sector partnership? So think about, your organization, and you're partnering with Feeding America. What's the focus of the partnership? What are the needs that you're hoping to address within this partnership? And there are no right or wrong answers. This is all part of the design process. So I'll give you all a couple seconds. Again, you can come off mute if you'd like, or just drop it in the chat. So you can pretend you're yes, Food for America is a organization that works with providing food to communities. All right, so here we got some answers. Food security, address food instability, nutrition insecurity. Great answers. And thank you for that question, Joseph. That was a really good clarifying question. Cultural awareness with food. That's a great one, Nalani. All right. Okay, I'd love to hear some other examples as well. So then these are just the potential partnership, the reason why you're partnering. Oh, we'll also hear from Amanda, chronic disease prevention and management through nutrition. Great. Access to health food options for health concerns. All right, I see that we're all getting on the same page. Oh, consolidation in the agricultural sector. Access to housing. Yes, it could be, right? Maybe your organization's really invested in housing and now you're working with Feeding America. What are some potential ways that you could be looking at this? All right. So the next question that we have within this empathize stage is, state the shared purpose and the ultimate impact you're trying to have on the population of focus in your community. So again, think about, you're in a suburban area, your organization is working with Feeding America. What in your partnership, what are you hoping to get? What are you hoping to do? And some of this may seem repetitive from what's already been dropped in the chat, but would love to hear what are some thoughts on this shared purpose. So think about the end goal in mind. Give you all a chance to think a little bit. This is the first time we're trying to do this activity through chat. So this is really interesting. Okay, great. Thank you. So we see decreased health disparities and social inequities amongst the populations in need, helping the community members navigate the system of community resources. Wonderful setup, a referral system between healthcare settings in the region and Feeding America food pantry sites. Wonderful, right? So these are just some examples of what the partnerships may look like, right? So I'm imagining right now, all of you would have very different mural boards, but this is just a taste of what that mural board would look like. All right. So we're going to go ahead and go on to the next part of this activity, which is digging deeper. And you see on this, on the right-hand side of the slide, there's 8 questions. We don't have time for all 8. So we're going to go with one of the first questions is visualize the population of focus. Who comes to mind and what are some of their personal attributes? So really think about the community, think about the patients, think about the community members, think about the clients. I know we use different terms to describe the folks that we engage with or that we serve. So who are they? Who comes to mind? Also think back to the demographics, like what are some things there that maybe you'd want to pull from? Great. So we have families that have recently moved to the area for economic opportunity. Okay. And then we also have single parent families with young children. We have creative, wise, ingenious. Yes, I love it. I love it. Rural queer families. Oh, that's a great one. Yes. So these are all the different people that exist in our communities, right? So this is just one part of this part of digging deeper. And so I'll go ahead and move us to the next question. The 4th question is, now let's think about them. What are some of their common everyday challenges? We also had another addition, aging farmers. Okay, great. So now that we've identified some of these different individuals or communities or pockets of the community that we serve, what are some of their common everyday challenges? And feel free to bounce off some of the ideas that are already dropped in the chat. All right, so we've got some challenges with transportation, cultural and language and financial issues, affording and accessing fruits and vegetables. Great. What about our single parents, single parent households? Yeah, there we go. Time, working multiple jobs, easy to go to McDonald's. Plain tired, yes. Trying to afford rent, limited public transit, navigating systems navigation, time. Yes, time is just really hard to come by these days. Childcare. So now we also have to think about, these are just some of the challenges that folks have to think of. All right. Well, thank you for participating. Again, this was just a very, very short taste of these 2 different phases of the design sprint. And I will say that this is probably the most powerful stages within the design sprint model of really going through as a partnership to outline your shared purpose. This slide right here has an example of what our team did last year to prepare for the design sprint. So we did our own mock design sprint. And this is not an example related to the example that I gave earlier, but we went through and answered these questions as if we worked at different organizations, and these were the responses that we came up with. So this is just a sample here. And then for digging deeper, this was, again, another really powerful activity, going through and really taking the time to answer each of the questions. It allowed us to really think about our individuals that we're serving, that we're caring for, and really thinking about, what are their strengths, what are their opportunities, what are their goals and motivations. All of these questions were so powerful in helping us get closer to the community and really have them in our minds as we worked with them. So again, this is the example from the mock mural board that we used last year. All right, so at this time, I'd like to ask the discussant for this session to take a moment to share their perspectives. And yes, these materials will be available afterwards. So yeah, so I know we have a discussant for this session. So really like to invite them to share their thoughts. Love to hear their thoughts. So we'll actually give the discussant a little bit of time to gather their thoughts. But let me just go back to some of the questions that I saw earlier in the chat. I know there was a question about, who participates in the design sprint, in terms of were the design sprint participants staff or patients. It was primarily staff. We encouraged them to bring patients or community members. With health centers, one of the unique aspects of health centers is that our board composition is usually 51% of consumers, of patients of the health center. For this year, we actually had one team that had one of their health center board members participate. So yeah, I think one of the other things too with the staff, many times they'd go ask their community members or their patients for their insights. And many times I'd say the staff represented the community as well. Obviously, it's not a replacement. It's a good way to at least have a good idea of what the potential needs are. But throughout the design sprint, everybody, their homework was always going back to the community, to actual consumers, clients, and patients to get their insights on what was being proposed. Nalani, I don't know if there's anything else that I missed with this question.
No, I think you answered it perfectly.
Let's see here. And then, yes, I know earlier in the session, there was a question about, is design sprint part of human-centered design? And it is, right? It's one of those, human-centered design is one big umbrella, and design sprint is just one part of that, one piece under that umbrella. And again, this was really a powerful exercise for all of us when we did this with our teams. What questions do folks have? All right, how do you manage contrasting perspectives when we're eliciting from the teams? I'll go ahead and give it a shot, and then I'll ask Nalani to share. How do we manage this? I say carefully, right? One of the things that we heard from the teams many times was having us as a coach. We were always that neutral party that could navigate those differences, right? And I think even then, there was times where there was differences of opinion. And so we'd manage that, we'd explore, we'd ask for more insights from the different perspectives. And so I think that was something that we were able to get from individuals. And it was okay. I think we also welcomed different perspectives, right? I think that was the other thing that the design sprint helped us navigate or mitigate was groupthink. And so we encouraged those different ideas. And sometimes, depending on the groups and the sessions, maybe I know there was times where I would add a different idea that was completely irrelevant, but just to get a sense of where they were at. Nalani, what?
Yeah, I mean, going off of that, we also created community norms and expectations at the very start and front. So we came in with a few, and then we opened it up for each of our teams to include a few others. So some of them was including yes and. We wanted to make sure folks knew that this was the start of the journey, not the end. That perfect is throw that out the window, and we are putting everything on the table and exploring it from all different perspectives. So we welcome different perspectives. And if there was any type of really contrast perspectives going on, it was the facilitators, which myself and Yuriko and a few of our other colleagues would help navigate that discussion to make sure that folks felt comfortable and safe to share their perspective, and their other team members felt comfortable to ask questions and to maybe pry a little bit more on that point of view.
It's interesting. I think the parts where it got a little bit, where we saw the most discussion, I'd say, was when in the design sprint, you have to narrow down all the ideas that you've identified and select one, and people were really hesitant to select one. I'm like, these ideas don't go away. They're yours. So work on this one idea now, but these other ideas are always here. So it's giving them permission to think big, dream big, put it on paper, but then also revisit it and reiterate with the community so that they're able to have a very, inclusive and equitable bank of ideas. So the next question here is, did we pay or incentivize community participants? So last year for the 2021 design sprints, we did not have any, we did not provide any incentive to the teams at all. This year we did, and we actually encouraged them and asked them to identify how they were gonna incentivize community members that were members of the design sprint teams. Nalani?
Yeah, that's right.
Okay. Not sure, did I see a hand earlier? Yes.
Yep.
Please, Adrian.
Hi, thank you. I just wanted to say thank you so much for highlighting this work. Our team at the Pima County Health Department in Southern Arizona is also using human-centered design and behavioral economics for our advancing health literacy work. And I'm so glad that the question about incentives came up, because I just wanted to share that we have been able to leverage the nature of human-centered design work to increase our what would be our normal participant incentives from the county. So normally, we're a kind of low-funded health department here in Southern Arizona. We haven't previously or historically had the means to really, I think, equitably compensate our participants, our community members, and even when the means were there, the practice wasn't there historically. And because human-centered design is really more involved than just taking a survey, we've been able to leverage that to start changing our policies and how we compensate community members. And I think it would be kind of an easy move for other health departments to do the same, just because of the nature of this work. So I just wanted to flag that as like another positive potential gain of engaging with this work from your health department, is creating more equity in incentivizing participation from community.
Exactly. Yeah, we have to honor their time and we have to honor people's time, right? So great. Thank you. There's a question about why did we incentivize? I think part of that goes with understanding that individuals from the community, they're taking time out of their schedules, they're prioritizing this particular initiative. And I think also understanding that their perspective and their lived experience is expertise, right? They've navigated these systems, they've navigated inequities, and it's a small token to acknowledge their navigation through the system. How much are they paid per hour? We don't have those numbers. I think the health centers and their community partners determined the level of incentive for the community members.
Right. And I would just go off and really emphasize, what Yuriko was mentioning, is that we want to honor the time that folks are dedicating to the design sprints process and journey, and know that they are bringing expertise of their local community that Yuriko and I and our other facilitators can't talk to. We can talk about SDOH all day, but I can't talk about Rock Hill, South Carolina and their needs particular, but those folks can, and we can help elevate their story and elevate what they need in their communities to the next level. Our incentive for this year was just a lump sum that we had an opportunity to do so, and we had asked the community health center with their partners to really strategically think about how they wanted to use these funds together, how they wanted to compensate the community members' times that they were bringing on board to participate in the design sprint, because we understand we're asking a lot of them and a lot of their time to come off from the field or from their day jobs to sit in with us and go through this experience.
So I want to thank everyone for their time. We're over time at this point. This is our contact information. Our colleague Sarah couldn't join us today, but she was very much a part of this creation and presentation as well. And if you, here's how to contact and follow NACC. So thank you all for your time, and we look forward to seeing you hopefully in the future.